The following podcast is part of a certified educational activity titled How to Make Multifactorial Clinical Decisions in HR-Positive, HER2-Negative Early Breast Cancer and Metastatic Breast Cancer, Guiding Precision Amid Growing Complexity. Access the entire activity and complete the post-test at peerview.com/SQE860. Downloadable slides and practice aids are also available.
So this is a symposium on how to make multifactorial decisions in hormone-positive, HER2-negative early and metastatic breast cancer. And I'm joined here, my name is Stephen Johnson, medical oncologist from the Royal Marsden in London. And I'm joined by my colleagues Matt Gertz from the Mayo Clinic in Rochester and Valentina Guarneri from Padua in Italy. So our goals today are to augment your knowledge on efficacy and safety of evolving therapies in hormone-positive early breast cancer and metastatic disease, look at your skills for formulating treatment plans for these patients, and equip you with the best strategies to manage adverse events to improve adherence and persistence with therapy. We've partnered with Living Beyond Breast Cancer, which is a non-profit organization that provides information for patients to help live with and beyond breast cancer, and we're grateful for their support. So the first part is to look at patients with early breast cancer, and we'll have 3 consecutive talks with a case spread through that 2-3 talks that will allow you to be interactive in the decision making. And then we'll start with that case now. So Samantha is a 62-year-old postmenopausal patient. She's had a screening mammogram that's found an abnormality in her left breast, and it's 3 centimeters with suspicious lymph nodes. Core biopsy confirms a grade 3 invasive ductal carcinoma, ER strongly positive, PR weak, HER2 negative, and an FNA from the lymph nodes confirms nodal involvement. Staging is clear. Germline testing is negative. She herself opts for a left mastectomy and axillary lymph node clearance or dissection, and there are 1 out of 3 involved lymph nodes. The tumor is 2.5 centimeters in size, and it is a grade 3 invasive ductal cancer. An Oncotype recurrence score is requested, and the result comes back with a score of 21. So this patient's already seen her surgeon for post-op follow-up, and then she comes to you in the oncology clinic for a discussion about her level of risk and subsequent therapy options. So without further ado, I'm going to pass over now to my colleague Matt Gertz, who will talk about risk assessment and identifying high-risk patients. And we'll come back to our case in due course. Matt.
Stephen, thank you. It's a pleasure to be with you today. I'm going to be talking about how to assess risk in patients with early breast cancer. So we're going to start out by focusing first on the natural history of hormone receptor positive HER2 negative breast cancer. What are the factors that we know are associated with recurrence? We'll talk about baseline, clinical pathological factors, those factors we've known about for many years. And then we'll also speak about a gene expression profile and these biomarkers that are being used in our practice more and more, and as was discussed by Stephen in this case. And then this emerging area, which we're going to be hearing more and more about, and we expect to potentially come into our practice fairly soon, and that is circulating biomarkers. So what do we know about the baseline prognosis for patients with breast cancer? Well, we've known for many years about these peaks in the hazard for recurrence. We know that in ER-negative breast cancer, of course, there's a very large peak in that first few years. And then in ER-positive, we know that there is actually a peak in between that years 2 and 3. And we also know that there is a peak that is actually seen later on, this risk for late recurrence. And that was seen nicely in this sub-analysis from the ATAC trial. We know, of course, from that trial that anastrozole was superior to tamoxifen, but you can see on the right lower hand side there, and that anastrozole seemed to smooth that risk down a bit in the first couple years, but we continue to see this later risk for recurrence. So what are the tools that we have at our disposal to treat patients in this setting? Obviously, we know that the drug tamoxifen provided large benefit compared to control, And now mostly in the postmenopausal setting, we utilize tamoxifen based on the meta-analysis demonstrating superiority of AI versus tamoxifen, now not only in terms of disease-free survival, but also overall survival. We also know that chemotherapy has been studied extensively in early-stage ER-positive breast cancer, and that although there is a benefit with chemotherapy, that benefit is modest. Last but not least, I did want to just mention, increasingly for those patients, of course, who have very high-risk characteristics, we treat patients in the neoadjuvant setting. Of course, we know that grade tends to be an independent factor associated with recurrence. And so for those patients that have very high biological risk, those patients are commonly treated in the neoadjuvant setting. And of course, one of the things we know is that residual cancer burden, utilizing information from the tumor bed, cellularity, number of lymph nodes, the size of the greatest metastases, that this information provides substantial prognosis and really separates not only early on, but as you can see out at the distant years. Whereas we know for ER-negative breast cancer, of course we know that if there's residual disease, there's a greater risk for recurrence, but most of that risk is within the first several years. So with that in mind, what are some of the other factors that might be utilized? Well, we know about Ki-67. This has been well tested in our modern day trials. Stephen will talk to you a little bit later about the role of Ki-67 in the setting of adjuvant CDK4/6 inhibitors. But what you can see here is that in early stage setting, this is actually from the big 198 trial, you can see that Ki-67 using a cutoff of 11% was prognostic, but it was not predictive necessarily of a hormonal therapy benefit. I mentioned that we're beginning to use gene expression profiles as really common practice, certainly in patients with early stage breast cancer. And this is just information about, in this case, the Oncotype DX recurrence score that was developed now well over 15 years ago. And what we know from this, of course, is that the recurrence score is prognostic. This is from the NSABP 14 clinical trial. And of course, a major question that came out was from this study was, is the recurrence score predictive? A secondary analysis, the B20, suggested this. And so this led to the prospective validation of the recurrence score, first in the Taylor RX trial. As you recall, the design of this trial, patients with node negative and recurrence score less than 11 received endocrine therapy alone. Of course, we heard that these patients did exceedingly well. Those patients that had a recurrence score of greater than 25 received chemotherapy, followed by hormonal therapy. And of course, the major question with this study was, is there a role for chemotherapy in patients in the intermediate recurrence score group? And the randomization, as you know, was hormonal therapy alone versus chemo followed by hormonal therapy. And very important, this was really a practice-changing study. We know that there is absolutely no benefit of chemotherapy in patients especially in the postmenopausal group, where we saw that the addition of chemotherapy did not improve either disease-free survival or distant disease-free survival. The RX Ponder was the next major study to read out. This was the study looking at really the same question, but this time in patients who had 1 to 3 positive lymph nodes. So these were patients, women greater than or equal to 18 years of age with 1 to 3 positive lymph nodes. And the randomization here was to either chemotherapy followed by endocrine therapy or endocrine therapy alone. And here the patients with a recurrence score of 0 to 25 were randomized. Stratification factors here, 0 to 13 versus 14 to 25 in terms of the recurrence score, and pre versus postmenopausal, and then, of course, axillary surgery. And one of the things that was identified in this study was that in postmenopausal women, there clearly was absolutely no benefit of adjuvant chemotherapy. really regardless of the number of lymph nodes. You can see here on the left-hand side, postmenopausal patients that were randomized either with 1 or 2 to 3 lymph nodes, that there was no statistically significant difference in terms of invasive disease-free survival. But interestingly, a difference in disease-free survival was seen for those patients who were premenopausal. And you can see that difference both in patients with 1 to 2 to 3 lymph nodes. And of course, this issue of the role of chemotherapy in this intermediate risk recurrence score in patients who are premenopausal remains really an unanswered question, given that the majority of patients in both the TAIL-RX as well as RX-Ponder trials received what most of us would consider inadequate endocrine therapy suppression. Well, what are some of the, finally, some of the additional assays that we're moving towards? Well, as we're beginning to see from multiple studies, and as Stephen will tell you later today from the Monarchy trial that was just recently presented, we're beginning to look at the role of circulating tumor DNA. Of course, we're using that routinely in the metastatic setting, but what about in the early stage setting? And I think one of the major breakthroughs has been the use of a tumor-informed strategy. In the tumor-informed strategy, some of this data came out now almost 10 years ago, and that's where a genetic footprint of the tumor, if you will, is obtained from the primary tumor, and then we track those mutations in the bloodstream. And using that approach, there was very early data that demonstrated that patients that had circulating tumor DNA post-surgery had a higher risk for recurrence. Now, these data, of course, were preliminary, but there's been subsequent studies, this out of the Dana-Farber group, again showing this same approach, utilizing the creation of a personalized, if you will, mutation analysis, then being able to detect those circulating tumor DNA in the bloodstream. And what you can see again in this analysis was that patients that had circulating tumor DNA had a much higher risk for recurrence than those whose circulating tumor DNA tests were negative. And now we're finally now beginning to see these data emerge in the setting of some of the larger trials. Many of you know PeNELOPE-B was a very important study. This was a study that took a high-risk population of hormone receptor-positive breast cancer who did not achieve a PCR after neoadjuvant chemotherapy, and it had a CPS-EG score of greater than or equal to 3 or greater than or equal to 2 with residual nodal status. And in this trial, as you know, there was no difference in terms of invasive disease-free survival comparing the endocrine therapy alone versus endocrine therapy plus palbociclib. But the authors in this study did a very similar tumor-informed analysis looking at baseline ctDNA detection. And as you can see in a subset analysis from the PeNELOPE trial, again, patients who had detectable circulating tumor DNA at baseline had a much shorter disease-free survival. You can see the hazard ratio here of nearly 9, highly statistically significant, both in terms of invasive disease-free survival as well as distant disease-free survival. So in conclusion, I want you to see that there is a variety of things that we as clinicians can identify in our patients that allow us to identify factors associated with the risk for recurrence. These include baseline clinical pathological factors, the use of gene expression biomarkers, as well as circulating biomarkers. And the real question, of course, that we're asked as clinicians and for our patients is, when do we escalate therapy and when might we de-escalate therapy? And this is an extremely exciting time, both as physicians and for our patients, because we can avoid overtreatment. But conversely, for patients who are at high risk, we have the opportunity to escalate. And the real question is, as we escalate, what's the best approach, and what are the escalation treatments that we will do? So with that, I'd like to turn it back to our moderator.
Thank you. So let's return. Thank you, Matt. Let's just have a brief discussion back with our case. So remember, this was a 62-year-old patient who had a 2.5 centimeter grade 3 tumor with one node involved and a recurrent score of 21. And we saw the voting that the majority of you were opting for extended adjuvant endocrine therapy, not necessarily chemotherapy. Valentina, what do you think in this particular case here are the key features? Is it biology or is it tumor staging, the node positivity and the grade? What really is your dominant factor in talking to this lady?
I think that we have to consider both the aspects, because we have a relatively young lady with one positive node, but also grade 3 tumor. And we know that also grade is one of the major determinants of the risk. And I think that personally, I will not recommend chemo because of the oncotype data. But I will not be totally comfortable with the endocrine therapy alone, because we have now data, and I know that you are going to discuss it, that we can really provide much better option rather than endocrine therapy alone.
Okay. Matt, in TAILOR-X, they did a subsequent publication that led on tumor size and grade as clinical features and layered that on top and showed that if you had low clinical features despite an intermediate oncotype recurrence score, you got benefit of chemo. I think it's been done to some extent in our responder as well. But if this in premenopausal patients in particular, do you think that's an important add-on in decision making?
I think it absolutely is. And, one of the unanswered questions in premenopausal breast cancer patients is that these are patients that are, more likely to have inherited, or if you will, pathogenic mutations in a number of different genes that may confer deficiencies in homologous recombination. So a major question, of course, is, does the chemotherapy benefit these patients? Is it simply because of ovarian function suppression, or is there some intrinsic benefit at the level of the tumor? These are things we're really trying to dissect out in the offset clinical trial, which is ongoing, looking at the question of, do you need to give chemotherapy to premenopausal patients when they're receiving optimal endocrine therapy?
So essentially, there are more biomarkers we could add on that we don't know about. We had a very good talk in the mini oral session just now about HRD and triple negative as being selective for benefit. So it may well come in hormone positive as well. So Valentina wouldn't give chemo. Would you give this patient chemo, Matt?
I would not. And so I think this case really presents we sort of look pre-CDK4/6. Here we have data, or we have level 1 data that suggests that this patient will not benefit from chemotherapy, but yet she remains at increased risk for recurrence.
Great. Okay. In terms of CDK4/6 inhibitors, we know that they're effective in metastatic disease. We know they overcome endocrine resistance. So if we're trying to enhance efficacy in early breast cancer, it was logical to trial them. And there are 4 key trials. Matt's alluded to PeNELOPE-B. Pallas was the other trial with palbociclib, but sadly, both of these trials were negative for the benefit of palbociclib, which leaves us with the 2 trials that I'll discuss with you, which is MONARCH-E in high-risk node-positive patients and NATALEE in a broader group of stage 2 and 3 patients, both of which trials were positive. And I'll give you my thoughts on those as we go along now. So let's focus initially on MONARCH-E. I think you're all aware of the design. This was high-risk node-positive patients. So in cohort 1, we're talking about 4 or more nodes, or if 1 to 3 nodes, another risk factor grade 3, or large tumor size. And we've calculated before in the design of this trial that could be associated with standard of care chemo and endocrine therapy with a residual level of risk of up to 20-25% at least at 5 years. A second cohort was added at the behest of the regulators to look in lower risk 1 to 3 node positive, say a grade 2 or a smaller tumor, where high Ki67 was the only risk factor. But this is a much smaller cohort and not fully mature. It was an open-label study, randomized patients after completed of surgery, radiation, and chemo were given either endocrine therapy alone or endocrine therapy plus 2 years of abemaciclib, with IDFS as the primary endpoint. These were the data presented at this meeting last year, published in JCO earlier this year, which are the mature 5-year data for invasive disease-free survival. I point out two things. Look at the orange curve, which is the rate of recurrence in the control arm. 95% of patients had had chemo because they're higher risk node-positive patients, yet at 5 years, 1 in 4 had already relapsed. If you look at the benefit of abemaciclib, it occurs early, and the curves continue to separate beyond the 2-year treatment period, a so-called carryover effect, so that you've got a 32% reduction in risk, an absolute benefit of 7.6% at 5 years. If you look at the various subgroups, they all show a degree of benefit, including the premenopausal patients, which are about 43% of the patients in the trial, hazard ratio of 0.59. Now, in terms of distant disease-free survival, which is metastasis or death for any cause, similar separation of the curves and hazard ratio showing a 32% reduction in risk of death or a distant event. The overall survival data at the moment remain immature because it is an event-driven analysis, and we have to wait and be patient in ER-positive breast cancer. These patients often, even if they get metastatic disease, live for a long time with further treatment options available. We can look at that by this set of histograms here, which is a breakdown of the distant relapse-free survival data, looking at either death or development of metastatic disease. And this is at the 3 time points of the analyses in 2021, 2022, and 2023, which are all the protocol-defined analyses. And what you can see emerging is that there is no difference in deaths not related to breast cancer, a numerical difference in deaths related to breast cancer starting to emerge, and a big difference in the development of metastatic disease. These patients are alive and on treatment, but half as many of them if they were on the abemaciclib arm. So the reduction in the development of metastases in due course may well translate into a survival benefit. Now, Matt alluded to Ki-67 as a strong prognostic factor, and these data here really confirm that. If you just look at the blue line, that's the endocrine therapy alone. The solid is the 20% or more. The dotted line is the less than 20%. So just with endocrine therapy, another data set showing that it's a strong prognostic factor. But if you look at the benefit of abemaciclib, it's the same with both high Ki-67 and low Ki-67. And you remember in the US, the initial label was just in the high Ki-67, but you have to wait a little bit longer in the lower risk patients, but the benefit is still there. And these data alone were what reversed the FDA's decision to allow them to broaden the approval in the US. Now, there are some data that have been published now on the various genomic features. My colleague Nick Turner presented these at San Antonio last year, and we've been able to do in 1,000 patients in the trial an inferred oncotype recurrence score. And 2/3 of the patients had high oncotype recurrence scores because they're predominantly grade 3 node-positive patients. But whether you had a high or a low oncotype recurrence score, benefit of abemaciclib seemed to be very similar. Likewise, we were able to do an assessment of intrinsic subtype, whether it's luminal A, luminal B, HER2 enriched, or basal. And again, there's no difference between luminal A and luminal B. As far as HER2 enriched and basal, the numbers get very small, so the confidence intervals are quite wide as to what the benefit may be, particularly in basal ER-positive cancers. Now, we talked about the potential of ctDNA to be a measure of risk of recurrence, and Shireen Loy presented these data from the Monarch-E trial at ASCO just gone. And if you look at the baseline ctDNA in the Monarch-E trial, if it was detected at the start of the study, and remember they completed their chemotherapy and their surgery and their radiation, if you still had ctDNA at the outset, you had unfortunately a much worse prognosis than if your ctDNA was negative. So yet another data set saying that this is a strong prognostic factor. And if you look at what happened in terms of the dynamics of the ctDNA in the study, again, the light blue is those that stayed persistently negative, whereas the dark green are those that were persistently positive. But if you look in the middle, are the ones that were red, that started negative and became positive. that predicted with a much worse outcome than those that started positive and then converted to negative. Now, these data are agnostic of which treatment arm they were in the trial, but it's just dynamic data to tell you that this is reflecting what's happening in the biology of the patient and reflecting what's going to happen to them in their risk of prognosis and recurrence. So the FDA approval, as I said, is expanded in the US now to all patients that meet the monarch-E criteria. The EMA approval is related to cohort 1, where it's patients that are 4 or more nodes, or of 1 to 3 nodes, one of the other following features. Now, I'm going to tell you a little bit about NATALY, which is the other trial, and there will be important new data presented on this trial in the early breast cancer session on Monday. So do wait around for that. This is a trial of similar size, similar design objectively in terms of an open label randomized trial, but a broader group of patients that includes stage 2A node negative patients. But if they were stage 2A and node negative, they had to have an additional risk factor based on either high Ki-67 or high oncotype recurrence score. And you can see that the patients here were on a 400 milligram dose, so lower than in metastatic disease, and they were on 3 years of treatment rather than 2. And they were all randomized to an had an aromatase inhibitor, and if premenopausal, had an LHRH agonist plus an AI. So their endocrine therapy was mandated. The data presented at San Antonio were the final, so-called final, but the protocol-defined primary analysis with a little bit more data than the original ASCO data that came out in the New England Journal of Medicine. So you can see here a hazard ratio of 0.75 and an absolute difference of 3.1, but this is at the 3-year point. The data on Monday we hope to see will be at the 4-year point, but the trial is positive. The trial is positive for the endpoint of distant disease-free survival as well. And when we started to see the data on nodal status initially presented at San Antonio, we could see that in the node-negative patients, although the numbers are small, the hazard ratio looked encouraging but had wide confidence intervals because the number of patients were relatively small. We had a little bit more update on the node-negative patients in this presentation at ASCO from Denise Yardley. And what you can see here is an interesting breakdown from IDFS, distant disease-free survival, and distant relapse-free survival. Now, you might say, what's the difference between all of these? Because the numbers change from 20 and 31 to 17 and 27 down to 12 and 23. So IDFS includes local recurrence, DDFS includes second primaries, non-breast cancer, and DRFS is just death or metastatic breast cancer. So there are other events in here slightly muddying the water, and I think we need to wait and see what the 4-year data, particularly in the node-negative patients, will be. So returning to our case of the lady with the 1-node positive 2.5 centimeter grade 3 tumor with an oncotype recurrence score, what adjuvant treatment options would you discuss and recommend with this patient? So I'm going to come back and sit down and ask Matt to start giving me thoughts on what you would do here.
The data that you demonstrate are obviously convincing, is that we have the ability to identify this patient as at higher risk. I think that what you showed was the data with endocrine therapy alone, even in the setting of chemotherapy, 1 out of 4 patients having an invasive event is a really high number. And so we have the ability now to escalate therapy. We can utilize a CDK4/6 inhibitor. Obviously, right now, abemaciclib is the only drug that's FDA approved. We hope that ribociclib will be approved as an option in the future, but clearly this would be a strategy that would use to improve this patient's outcome.
Okay, and Valentina, do you agree? I mean, you weren't keen on chemotherapy, but if you reflect on this patient having, she would have been eligible for the monarch-E trial based on 1 nodes and grade 3, so she would have been recruited into the trial.
I would not offer chemo because of the oncotype data reassuring. So I think that CDK4/6 inhibitors are a good option for improving their chance for cure. So
now, a lot of people have asked me, what are the comparisons of CDK inhibitor versus chemo in the early breast cancer setting? And the answer is we haven't got any data. monarch-E was 95% had chemo, NATALY 88% had chemo. So the non-chemo groups are so small, you can't do a proper statistical analysis on matched patients. There are neoadjuvant trials. Carabella, the GICAM study from Miguel Martin, is a head-to-head comparison in high or intermediate risk of chemo versus CDK inhibitor therapy. And then the ADAPT cycle study is a biomarker-selected adjuvant treatment option of CDK inhibitor versus chemo. So the direct comparisons with chemo will emerge in the forthcoming trials. There's a question here. We've got time for a few questions. Oncotype is out of reach from Chris for many. How would we act in the first place if we don't have Oncotype? Can we use Ki67? Is that a valid surrogate of the biology of this cancer? What would we think the Ki67 would be with an Oncotype of 21?
Of course, if we don't have access to Oncotype or genomic tests, I think Ki67 is showed the data that is clearly a prognostic marker. So I think it can be helpful to select those patients at higher risk, not specifically to inform on CDK4/6 yes
Correct.
or no, but to estimate the risk of the patient can be.
Because I think the other thing I would note here that the PR was negative, grade 3, likely to be a luminal B. Oncotype's 21, not low. So I think a Ki67 is probably quite likely to be over 20%. And that starts to give you an estimate of risk of recurrence approaching 20-25% at 5 years. Matt, if this was a grade 2 tumor, say your pathologist, it was very on the fence, and between grade 2 and 3 can be very subjective. If it was grade 2, she doesn't actually meet the criteria. What would you do in that situation? You haven't got ribo available. What would you do there?
Yeah, well, I think obviously in that situation, we would be really relegated to still optimizing our endocrine therapy approaches. One of the options on the screen was to utilize even longer duration of endocrine therapy. And obviously this is a bit of a controversy. We expect data from the EBCTG that will come out actually soon with regard to the role of extending therapy beyond 5 years. But then I think if we don't have a CDK4/6 available, then we have to think of other strategies to escalate our therapy. And clearly, if we have the recurrence score of 21, if that's available to us, we know that chemotherapy is not going to improve the outcome. So then we have to be thinking of other strategies.
And obviously, if ribociclib is approved in this scenario of N1 cases that are grade 2, that would be an option that you would have. If Oncotype recurrence scores were 5, Valentina, do you think that would steer you away and just say, very low risk cancer, I give you chemotherapy? It would be a bit bizarre, I must admit, if it's a grade 3 and a low PR, but you might say, try again on your Oncotype. But would that change you if the Oncotype was very, very low?
But
for
I think
CDK,
that,
as I mean,
yeah,
for
I
CDK.
think that yes, for CDK, probably not, because you show the data, and this is of course not this is not validated to identify the benefit of CDK4/6, and I think that CDK4/6 helps in improving the performance of endocrine therapy.
Yeah.
So it makes sense to offer to discuss CDK.
And Stephen, I think if I recall in your slide that you looked at, the inferred recurrence scores from monarchy, I think most of them were actually quite high, as I recall.
Yes, they were. Only 33% were less than 26. I think we're going to try and see if we can do a step analysis like you presented, Matt, for the ER, PR, and Ki67, because I think a step analysis on Oncotype, the 5, the 10, the 15 would actually be informative. So I think that's in the plan as we increase the number of patients that we're doing the translational research on. A couple of questions, and then we're going to move on. Are we really curing patients with CDK inhibitors, or are we just delaying recurrence? I'll give you my take on that. We don't know yet. But if the curves continue to separate and there is a real carryover effect, my belief is that that's a change in the natural history for a proportion of the patients. So 8 out of the 25 that will be relapsing, so a third, are not recurring. If they never recur and they're potentially cured long term, then I think for a proportion, you may have actually cured or altered the natural history. If the curves come back together again, then that's more suggesting that you're delaying it. So I think, to me, the separation of the curves is quite instructive about that particular question.
Stephen, can I make a point? I think one of the slides, again, that you presented were quite compelling is just the fact that twice as many people are living with metastatic disease, and the burden of living with metastatic disease is substantial for all of us, for our patients that we take care of. So even though we don't have the data with overall survival, that'll take a while. I think that's a very compelling data set or data points that we should emphasize as well.
Yeah, I agree. Let's return to our case here. And she starts the abemaciclib. She's taken treatment and she's had some persistent and recurrent diarrhea. She's had a little bit of arthralgia related to her endocrine therapy. She's had a short break from the abemaciclib, but got worried because of her risk about being off treatment. She's starting to take it again and still getting grade 2 diarrhea. So what are you going to do? Okay, Valentina is going to take you through the data on the toxicity.
Thank you, Stephen. So my role today is to discuss a little bit how to manage adverse events, but also in how to improve treatment adherence in this subset of early breast cancer patients. And as you know, the adherence is a multidimensional phenomenon, as is influenced by a lot of factors, some related to patients, to the treatment, to the disease, to the healthcare system, and also to social and economic condition. And of course, I acknowledge that some of these factors are out of our control, but I think that we can focus on some key aspects, such as, for instance, the perception of the necessity, the quality of life, the management of adverse events to improve patient adherence to treatment. So what is important to remind is that the non-adherence rates are somehow higher than that expected and are frequently underreported. I found really interesting the results of the CANTO trial. In this trial, the adherence to tamoxifen in premenopausal patients was assessed by self-declaration and by serum assessment of tamoxifen level. And what is interesting to me is that a significant proportion of patients declaring to be self-declaring to be adherent to the treatment turn out to have suboptimal level of tamoxifen as per serum measurement. And of course, in the past few years, we have seen the important results of adding ovarian function suppression to hormonal therapy, in particular in high-risk premenopausal patients. And with ovarian function suppression, of course, we increase the burden of side effects. And you know that adverse events are one of the key elements of non-adherence to treatment. And if you can see here, we have up to 23.7% of the patients that early discontinued treatment in the analysis of these trials. These are data from the Big 198 in postmenopausal patients, where you can see a similar phenomenon. You can see that more than 15% of the patients early discontinue treatment, and the rate of discontinuation is higher in the sequential treatment. This can possibly be related to the fact that switch to a different treatments change the side effects and increase the rate of non-persistence after to the treatment. And why it is so important to that the patients stay on therapy? Because we have a lot of data clearly showing that non-adherence compromise treatment efficacy, and we have worse outcomes in terms of distant disease-free survival, but also in terms of overall survival, showing a detrimental effect of non-adherence to the treatment. And you have seen the important results of the monarchy trial with the efficacy data at mature follow-up. But of course, we have to deal with the known safety profile of abemaciclib, and you know that we have an increase in the burden of side effects, in particular of diarrhea and fatigue, which are the highest side effects reported in a monarchy trial. And what is important to me is that in the monarchy trial, we have approximately 9% of the patients that discontinue treatment without prior dose reduction. And this is something that we have to avoid in our clinical practice for our patients. and staying focused on the diarrhea, which is the side effects reported by the patient in our case, you can see that diarrhea tend to occur early. In particular, grade 2 or 3 diarrhea tend to occur in the first few weeks of treatment. So I think that the first 3 months of treatment are crucial to apply dose adjustment to improve safety and to help the patient stay adherent to the treatment. And this is just a summary of the main side effects, as well as the way to prevent and control these side effects. And you can also download some additional information. And as summarized here, when focusing on diarrhea, you can see that in case of persistent or recurrent grade 2 diarrhea, we can interrupt treatment until return to grade 1 and start at the next lower dose. And we know that these are effective way to manage side effects. And most importantly, now we have additional information also on the efficacy in the adjuvant setting in terms of what happened if we reduce the dose because of the appearance of side effects. This is a recent publication from the Monarch-E trial, where you can see that if we have to reduce the dose because of the appearance of side effects, the efficacy of treatment is maintained. And I think that this is really an important information to be conveyed to the patient. And also this, again, is another interesting analysis from the Monarch-E trial, evaluating the baseline factors associated with the increased risk of treatment discontinuation. And of course, you can see that some of these factors are, I have to say, expected, such as age higher than 65 years, or equal performance status 1, or postmenopausal status, or having 4 or more pre-existing comorbidities. I found very interesting the data showing that a patient with from 1 to 3 positive notes has a higher rate of discontinuation and as compared to the patient with 4 or more positive notes. And my personal interpretation of this finding is that in patient with 4 or more positive notes at the time of the conduction of the trial, the perception of the benefit was higher. And you recall from the first slide that the perception of the potential benefit of the treatment is one of the main determinant of the patient-related factors for the influencing treatment adherence. Again, quality of life is another very important issue, in particular in the condition of the early setting of the disease. And these are the analyses related to the long-term patient-reported outcomes in the Monarch-E trial. In the Monarch-E trial, you can see that the patient-reported outcomes were evaluated not only during abemaciclib treatment, but also up to 1 year after treatment discontinuation. And here are the main findings. No major differences between the two arms in the score "I'm bothered by side effects of treatment" or "I feel tired." Of course, when looking at the diarrhea item, we see difference, and you have here the results. But again, no overall difference in the total score between the two arms, and a complete recovery to baseline condition at treatment discontinuation. Of course, we have to consider that patients receiving CDK4/6, receiving abemaciclib, also are receiving hormonal therapy. And we have to take in mind the side effects of hormonal therapy, including mostly related to the endocrine manipulation, so flashes, fatigue, sexual dysfunction. And we now have a lot of strategies that can help improving these symptoms. But I have to say that, at least in my country, it's very difficult to have access to this, to some of these intervention in our routine clinic. And this is just a suggested flowchart reinforcing the importance to counsel patients to address side effects, the importance of having a multidisciplinary team skilled in evaluating these side effects, and the importance of evaluating not only to record the grade or of the toxicity, but to evaluate the impact on patient quality of life, and to have discussion with the patient that sometimes we can change the endocrine backbone, we can try to minimize the side effects of treatment overall to have, of course, improvement in treatment adherence. So this is just a conclusion, a summary slide. I think that we have to work on a patient-centered approach, including patient education, counseling, routine monitoring, and management of side effects to help patients stay on treatment. And thank you. Beth?
Thank you, Valentina. So let's come back and have a little chat about the management of this patient. So would we do anything different to affect and manage her diarrhea? And should we obviously reduce the dose? Matt, the publication that you've just had that comes out on dose reductions, I think is very helpful because in actual fact, the Kaplan-Meier curves, the lines that were on top were the lower dose. It wasn't a sort of gradual reduction in efficacy as you lowered the dose. It was a gradual increase in efficacy technically. Do you think that's because of the ability to stay on? How do you interpret that?
Yeah, so first of all, doing these types of analyses where you are looking, as in this case, a secondary analysis to look at the impact of dose and dose reductions have to be done very carefully because there's always potential bias. And I would say that the way that we did it in Monarchy was to really adjust for those potential biases. And again, what we observed was that for those patients that required a dose reduction, there really did not appear to be any detrimental effect on disease-free survival. I think this is very important, and it brings up two issues. Number one is, people might say, well, does that mean that I can start my patient, with the 50 milligram per day dose?
Yeah, that's one of the questions here, actually. Yeah. Can we start at a lower dose?
And I think the answer that we clearly don't have that. I think what we can say is that we know that the pharmacology for these drugs is vastly different as you go from one patient to another, and that what may be the right dose for one patient might be a bit different. I think overall, the FDA-approved dose of 150 milligrams twice daily, it has been shown to be a dose that's tolerable and yet is quite effective. But yet we see patients in the clinic that do certainly require a lower dose. And we have now we're very quite confident, both, by the way, from Monarch 3, where we did a similar analysis in the metastatic setting and now in the adjuvant setting, that if we need to reduce the dose, we can do that confidently.
Yeah, I think that's very reassuring for patients. Valentina, what practical tips when you're starting to talk to a patient that's going to go on adjuvant abemaciclib, they're recovering from their chemo and their radiotherapy, they're a bit exhausted, they know they've got an increased risk, and yet you're talking to them about a treatment that's got more side effects. How do you keep them on board with you in that first couple of months of treatment? What are the key practical things you need to do?
Yes, the key practical tip is to have loperamide in her pocket, because we know that they have to take loperamide at the first sign of loose stool. And also I encourage patients to adapt the diet, because some patients reported that having a small meal rather than a big meal can be helpful. And of course, I say take the first months as a test and see what happens. You know that you can call me if you have more than an increase in the stool. You can safely stop the treatment and see what happens. And the importance is to be there for patients if they have questions. But I think that it's something that don't have to be viewed as so much increase in the burden of visit, because we can have some remote consultation or have. And also, I think that in Italy is quite difficult, but I think that nurse can be very useful to have this monitoring in the first 2 months.
I think it's the single most important thing. I've had a lot of reluctance from people up and down the country in the UK to start to do adjuvant CDK because of the increased burden on their clinics and workload. That's not a reason to not give a patient at increased risk therapy. So you have to adapt to your clinical practice. If you give all that patient the information up front and you have that phone call, the loperamide pre-prescribed, they don't take it preventatively, but they take it at the first sign of loose stool. Fluids, modify, stop the drug, contact the nurse or the doctor. And if you make that effort in the first 2, 4, 6 weeks, it pays off, because the incidence is greatest in the first 2 months. It drops down. And then if you have to dose reduce, and in the trial, we dose reduced in 43% of patients, and yet they still get the degree of benefit. So that effort in the first 2 months is worth it to get patients on board with therapy. So before we move on, we'll just have a couple of other questions here. Matt, how safe is it to start, message from Kim, how safe is it to start adjuvant abemaciclib during radiotherapy? Or should you wait until the end of radiotherapy? Just a practical question for those who don't know.
Yeah, I think this is still somewhat of an unanswered question. There are some preclinical data suggesting that CDK4/6 inhibitors may sensitize to radiation therapy. In the Monarch-E trial, patients had completed all of their adjuvant therapy and then went on to receive the CDK4/6 inhibitor. So I think right now the preference, of course, would be to treat patients after completion of the radiation therapy.
Yeah, and I think that's certainly my practice as well. In the trial, they had to be, you got within 12 weeks of completing your last non-surgical treatment, and you can have started the endocrine therapy already beforehand. Now, endocrine therapies themselves give side effects. So another question here is, if the patient stops the aromatase inhibitor due to adverse effects, so joint stiffness, whatever, all the things that they can't tolerate, and you showed some signs on that, particularly when they switched from tamoxifen, is it reasonable to go back to tamoxifen with abemaciclib? Because Monarch-E was very different to Natalie in that respect, because tamoxifen was allowed, but it's not without its challenges. Valentina, do you want to tell us about that?
The point is that in Monarch-E was allowed to have tamoxifen, not in Natalie because of the problems of interaction for QTc prolongation. Of course, tamoxifen is not my preferred choice in a high-risk patient, but I think that tamoxifen is better than nothing. A note of caution for VTE, because that in the Monarch-E we have numerically higher VTE events in patients receiving tamoxifen, but I think that we can screen the patient for risk of VTE, and I think we can safely administer tamoxifen.
Okay. Another safety question here. How common is a rising creatinine, and should you be worried about it? Who wants to take the creatinine question?
So I can take that. So, abemaciclib is a drug that is known to inhibit the renal secretion of creatinine. And so one of the things we've gotten very adept at doing is just in our patients where they're being followed and there is an elevated creatinine, to utilize cystatin C, which is a better way to follow the renal function. Obviously, one has to be a bit careful about completely relying upon creatinine, because you could have a patient that truly does have some renal dysfunction, let's say because of diarrhea, dehydration, etc. But in general, when one is following renal function, if the creatinine is elevated and there's a concern, please check a cystatin C.
Yeah, and I think it's a good point, because I've had letters from primary care physicians that done a blood for another reason, suddenly seen a 20% increase in creatinine, and they think they've got an AKI. So it's totally reversible, because it's an impact on the transporter protein rather than a real fact. So final question before we move on to the last bit on metastatic is about fatigue. Valentina, do you have any advice or tips how to manage fatigue on abemaciclib? Because it was the third adverse event after diarrhea, neutropenia, then fatigue. And all these patients have come off chemo and radiotherapy. So we're starting from a baseline that's low. You showed the QOL data. Is that an indication to dose reduce fatigue? Or how do you think you deal with that?
Of course, this is something that is very difficult to measure. But in case of the patients suffer from fatigue, we can reduce the dose. We have to recommend patients to try to stay active. And sometimes it is something strange because you say, okay, I say that I feel tired, and you say you have to do physical exercise. But we know that this can be progressive increase in physical exercise can be very helpful in managing fatigue.
Good. Okay. So Thank you very much for that. So we're going to move on to the last 30 minutes of the session. So well done for still being here. Hope you can do 30 more minutes, because we're going to focus a little bit now on our patient with metastatic breast cancer, some new data and a couple of cases just to get us thinking. So I'm going to give you the first patient, Mildred, who's 61, and she had a previous breast cancer treated by breast-conserving surgery, chemotherapy, radiation. She had a node-positive grade 3 cancer, very much like our Samantha lady. And she had a history of cardiac disease, so she was taking some medication for that. And she completed her 5 years of aromatase inhibitors. 3 years later, off adjuvant endocrine therapy, she presents with hip pain. Workup subsequently shows lytic bone disease, and staging shows evidence of some liver as well as bone involving spine, hip, and rib. She has a biopsy of the liver disease. It's still hormone positive, PR negative, HER2 negative, which is exactly the same biology as the primary breast cancer some 8 years ago. She has some genomic testing done on a ctDNA sample, and there are no targetable mutations. A performance status is 1. There is a second case. I'm giving you this now because we put this in as a second-line question, but we're going to see the case now. This is a 58-year-old lady who'd received first-line treatment, palbociclib letrozole, but after 18 months progressed in bone with new liver. So it's a separate patient to the one. She has no mutations and no BRCA mutations. So she is progressing on a CDK inhibitor plus an AI, and you have to think about what your second-line options were. And this is bone and liver, and she's only had 18 months of benefit from frontline treatment.
Stephen, thank you. So we're going to switch our focus now, as Stephen said, in focusing on the latest evidence in the use of CDK4/6 inhibitors in the metastatic setting. So you can see the outline that I've provided for you here. We'll first talk about the first line setting. We'll talk a little bit about this question, and that relates to if you choose the optimal CDK4/6 inhibitor, does the type of endocrine therapy matter? Then we'll switch gears and talk about some novel endocrine therapies, many of them that are in development right now. It's a very exciting time. And then finally, we'll end with the use of CDK4/6 inhibitors beyond progression. So this is the evolving treatment landscape of hormone receptor positive advanced breast cancer. And the one thing that I like about this slide is that, if you look over this period of time from the 1970s even to 2012 and 15 and 17, is that we really had very few drugs and the pace of approval was slow. But in the last 10 years, things have picked up considerably. Obviously, with the FDA approval of palbociclib, ribociclib, and of course, abemaciclib, and then subsequently, we're bringing in the drugs, the targeted drugs, PI3 kinase inhibitor drugs, now recently capivasertib, and of course, elacestrant, an oral SERD. So let's talk about, first of all, CDK4/6 inhibitors in the first-line metastatic setting. As you can see, there's been a series of trials that have been conducted. PALOMA-1 was really the first trial, very important trial that showed the large improvement in median PFS. PALOMA-2 was the confirmatory FDA registration trial. MONARCH-3, and then MONALEESA-2 and MONALEESA-7. And one of the things that you should notice is that in these trials, there was really almost a doubling of PFS in most all of these trials. You can see going from 10 to 20 months with PALOMA-1, 14 to 24, 14 to 28. So very robust improvements in progression-free survival with all of the CDK4/6 inhibitors. But interestingly, when it comes to overall survival, this is where we've seen some differences. We know that, of course, in the trials that evaluated ribociclib in the metastatic setting, there's been very consistent improvements in overall survival. You can see hazard ratio almost identical in MONALEESA-2 and MONALEESA-7. And then with MONARCH-3 that we just recently reported out, a hazard ratio of 0.80, and this did not quite meet statistical significance, had a p-value of 0.067. And for PALOMA-1 and for PALOMA-2, most importantly PALOMA-2, there was not an improvement in overall survival. You see the hazard ratio there of 0.96. So what are some of the reasons? Of course, there's a lot of questions. When the data first came out, the view was all of these CDK4/6 inhibitors are the same. As it turns out, that's actually not the case. And as time is going on, we're learning about some of the potential reasons why. Of course, on this slide, it's a somewhat busy slide, but I'll just point out to you that some of the differences that people have focused on is the ratio of CDK4 to CDK6. Both ribociclib and abemaciclib tend to inhibit better the CDK4, and of course this can be very important as it relates to one of the side effects that we see when you target CDK6, which is neutropenia, and that leads to this sort of on-off type of strategies, which can potentially lead to perhaps less beneficial effects long term. The other thing, of course, we know about abemaciclib is that it has other effects other than just targeting CDK4. It has additional activity on several other kinases, and this has been thought to be potentially one of the reasons why the drug also not just inhibits proliferation, which all the CDK4/6 inhibitors do, but one of the things we've seen is that the drug induces apoptosis. So here are the phase 3 MONALEESA-2 trial. Again, a very important trial in the first-line setting where we saw an improvement in overall survival with a hazard ratio of 0.76, a p-value of 0.008. Notice that the improvement in overall survival was approximately 12 months. For PALOMA-2, I mentioned this previously, is that there was not an improvement in overall survival. One of the thoughts was that potentially, and this was a post hoc analysis, perhaps that there was some missing data as it relates to survival. But even in this post hoc analysis, this finding was still not significant. And then in the MONARCH-3 trial, these data, as I mentioned, were just recently published. The addition of abemaciclib to a non-steroidal aromatase inhibitor improved the median overall survival from 53.7 months up to nearly 67 months with a corresponding hazard ratio of 0.80. But again, this did not meet statistical significance. So what are some of the differences between the MONARCH-3 and MONALEESA trials? Well, there are some important things as to why the MONARCH-3 trial that the statistical significance was not quite reached. I think, as you can see, one of the main factors is the design. So the MONARCH-3 was a 2-to-1 randomization versus the MONALEESA-2, which was a 1-to-1 randomization. And of course, that really leads to more statistical power. You can see in the ribo arm and the placebo arm, 334 patients as opposed to the MONARCH-3 trial. The other thing, of course, that potentially may impact is the use of post-study use of CDK4/6 inhibitors. And in the MONARCH-3 and in MONALEESA-2 trial, you can see there was actually similar findings. But I think this is probably one of the more important points, and that is at the early interim analysis 2, the improvement in overall survival corresponded to a hazard ratio of 0.754 with a p-value of 0.3. And this is actually, in some ways, quite similar here to what's seen with the MONALEESA trial. But at the final OS, that finding or that observation was not quite statistically significant. So I think that in terms of the two trials, that perhaps slight differences in study design may be one of the reasons why that there are one trial did meet statistical significance and the other trial did not. Well, let's move on and talk about endocrine therapy. So this is, I think, beginning to be a really interesting area in the CDK4/6 setting. And the question, of course, is, does the type of endocrine therapy matter? These are data that you're all familiar with. They were published now almost 8 years ago in the Lancet, comparing anastrozole versus fulvestrant in the first-line treatment of metastatic ER-positive, HER2-negative breast cancer. And as you recall, that fulvestrant did improve progression-free survival compared to anastrozole. But as you may have heard, actually I think it was a year ago here, the final overall survival between the two arms was not statistically significant. Well, what about in the era of modern day CDK4/6 inhibitors? And this is the Parsifal trial, where patients in the first-line setting received palbociclib, and the randomization here was to either letrozole or fulvestrant. And what you can see here is that in this particular setting, the type of endocrine therapy did not seem to make a difference, with no statistically significant differences in PFS. Well, this is important because one of the things now that we know is that in the treatment of patients with metastatic hormone receptor positive breast cancer is we've defined some of the most common reasons for resistance. And of course, about 10 or 12 years ago, we began to see some of the data emerge with regard to the role of ESR1 mutations as a well-defined mechanism of resistance. Now, it's important to note that ESR1 mutations are either not present or present at an extremely low frequency in the early stage setting. So in untreated patients, we just don't see these mutations. But these mutations arise in the setting of hormonal therapy, and in particular, aromatase inhibitors. And so in that setting, there have been a number of questions, of course, and that is, what is the optimal endocrine therapy for the treatment of ESR1 mutations? This was a very important trial, the PADA-1 trial, that took the approach to say, listen, let's actually follow patients serially, and at the first presence of the ESR1 mutations, let's look to see whether the type of endocrine therapy matters. And you can see in this study, patients at the time of identification of a rising ESR1 mutation or the presence of one were then randomized either to continue on with palbociclib along with their standard endocrine therapy versus the same CDK4/6 inhibitor palbociclib, but switched to fulvestrant. And of course, as we know, the switching strategy led to a marked improvement in progression-free survival with a stratified hazard ratio of 0.61. And so I think with this, I view as the first shot across the bow about what is the optimal endocrine therapy, and also when should we use this therapy. So this is the SERENA-6 trial, which has a follow-up trial, very, very important trial that is looking to really validate this finding from the PADA-1 trial. Again, taking patients in the first-line setting who are being treated with a CDK4/6 inhibitor and a standard first-line aromatase inhibitor, surveying them for the presence of ESR1 mutations, and when they are present, to then randomize those patients to continue on with the same CDK4/6 inhibitor along with their aromatase inhibitor, or to use that CDK4/6 inhibitor and switch to camizestrant, which is an oral SERD. This strategy of doing the switch at the time of emergence of the ESR1 mutation, I think is going to be very important. We really look forward to the results of this trial. Well, this is beginning to be a very busy place in the setting of strategies to target the ER. You know, we went from a period of time where we only had tamoxifen to 3 different third-generation aromatase inhibitors and to use of fulvestrant, to now what I would review as almost an explosion of new drugs that are being studied. And these drugs that have been studied now, we recently had the FDA approval of elacestrant, an oral SERD, but there is a series of other SERDs that are in development. You can see them here. But also important that there is a number of SERMs that are also in development. Then we have drugs including PROTACs, drugs that target the ER, as well as other mechanisms, including SERANs as well. So this is an extremely exciting time. We're not going to go into all this, but suffice it to say, we're going to be faced with some new issues, and that is, what's the optimal way to treat our patients in terms of endocrine therapy in the metastatic setting. And eventually, of course, these drugs will move into the early stage setting. Well, I'm going to end with just talking about the use of CDK4/6 inhibitors beyond progression. This is, of course, a very important question. We have, up until this year, we had really 3 main trials that looked at this: the MAINTAIN, the PACE, and PALMYRA trial. And these trials looked at those patients that had mainly received first-line palbociclib, and you can see the duration of their, whether there would be a benefit of continuing a CDK4/6 inhibitor. In the MAINTAIN trial, patients were switched to ribociclib. There were a few patients that started out on ribociclib, but again, most of the patients, as you can see, were treated with first-line palbociclib. And what we saw from this relatively small study was that there indeed was an improvement in PFS. The PACE trial, however, which looked at the role of continuing palbociclib, and the PALMYRA trial did not show statistically significant improvements. So this has led to the question, of course, what about the role of abemaciclib? The abemaciclib question was addressed in the post-MONARCH trial. These data were presented by Dr. Kalinsky at the recent ASCO meeting. And we hope to hear data soon from the EMBER-3 trial, which is a trial that randomized patients to look at 2 different questions: the question of a SERD, and then the question of combining, in this case, a SERD with abemaciclib. But let's talk a little bit about the post-MONARCH trial. You can see the trial design here: patients with advanced breast cancer who are progressed on a CDK4/6 inhibitor plus endocrine therapy, and patients in this case were randomized to abemaciclib fulvestrant versus placebo fulvestrant, with the primary endpoint being investigator-assessed PFS. Here you see the baseline characteristics. A few things just to note is that there were a little bit of imbalances in terms of those patients that had prior CDK4/6 duration, greater than 12 months versus less than 12 months. And then in terms of, you can see also the median prior CDK4/6 duration. Important to note again, this trial was mostly patients that had been treated with palbociclib, although there was a greater number of patients treated with ribociclib. At the first interim analysis, the post-MONARCH trial, the addition of abemaciclib plus fulvestrant improved investigator-assessed PFS. But what was presented at San Antonio demonstrated that, interestingly, that the final 6-month the final investigator-assessed PFS, although there was a statistically significant improvement, what was quite interesting was that the placebo arm, fulvestrant arm, actually did quite well. And so this led to a smaller delta in terms of the final improvement in PFS. Nevertheless, this is the first randomized phase 3 trial that clearly demonstrates that adding, in this case, a CDK4/6 inhibitor in the second-line setting, in this case abemaciclib along with fulvestrant, led to an improvement in PFS over fulvestrant alone. Here you see the forest plot. I won't spend a lot of time on this. What's very clear is that you can see a large benefit in those patients that had prior palbociclib. And I would just caution you that, again, with regard to ribociclib and abemaciclib, the numbers there were relatively small. So our conclusions here, I think, is that it's without a doubt is that CDK4/6 inhibitors have transformed the treatment not only of early breast cancer, as we just heard about it, but obviously in the metastatic setting. In the first-line setting, our choices we should be individualizing. We have no evidence to date that the type of endocrine therapy matters in the first-line setting, but clearly there seems to be differences in overall survival in terms of the choice of CDK4/6 inhibitor, but yet no head-to-head data. ESR1 mutations are a common mechanism of resistance, and what we see is that in this setting, these novel SERDs and SERMs appear to exhibit the greatest anti-tumor activity against ESR1 mutated disease. And then finally, in this post-CDK4/6 setting, we now have level 1 data that abemaciclib prolongs progression-free survival and increases response rates, and is a new option for our patients in this setting.
So Valentina, to talk about individualizing the selection of CDK inhibitors.
So thank you. So I will go back to the selection of first-line treatment. And this is just a summary of the ESMO guidelines, where you can see that we have a clear recommendation for offering hormonal therapy in combination with the CDK4/6 inhibitors unless the situation of imminent organ failure, where chemotherapy remain an option. And Matt already described you the data of a pivotal registrational trial of CDK4/6 inhibitors in endocrine-sensitive and endocrine-resistant disease, so in combination with AIs, in combination with fulvestrant. And why I'm showing you again these data, just to discuss with you that at the time we have only the results of PFS, we really can conclude that the three CDKs are the same, because you can see very consistent results in all the trials evaluating these agents. And all of us, I think, decided on the basis of the safety profile, because what Matt highlights on the different activity on the spectrum of the kinases has an impact on the type of side effects and also on the schedule of the treatment. So we have the continuous daily dosing, because neutropenia is not so problematic with the abemaciclib, and we have the 3 weeks on, 1 week off with the ribo and palbo. So in the end, we all made this algorithm taking into account the activity of the three molecules as well as the safety profile. So for instance, I would not have offered ribo in a patient with a lot of concomitant medication with potential impact on the QTc prolongation, as well as I would not have offered abemaciclib in a patient, for instance, with inflammatory bowel disease who is already at risk for developing diarrhea. But what I think it's very important that in the past few years we have seen the maturity of the data also in overall survival, and we don't have to forget that OS is our goal when treating patients with the metastatic breast cancer. And you can see that we have this achievement of a significant difference in OS with ribociclib in all the trials, and with the MEBA in combination with fulvestrant. And Matt already discussed with you the data from the Monarch 3 trial. Anyway, even if we cannot claim the statistically significant from the statistical plan of the study, we have more than 1 year gain in the setting of first-line treatment in endocrine-sensitive disease. And I think that with this consideration in mind, I think it's something that we have to discuss with our patients. So the three are not the same. And also, when looking at the response to the polling question on our clinical case, I think that most of you agree with me. But we also now have, I have to say, some standardized way to graduate the benefit of the treatment. So the ESMO magnitude of clinical benefit scale will develop with the aim of having a standardized tool to help clinicians, so oncologists, but patients and also policymakers make informed decision, in particular in a situation where we have multiple options, multiple choices. So the magnitude of clinical benefit score is including a lot of factors, and you can see that enhance the role of the direct endpoints such as overall survival and quality of life, rather than surrogate endpoint such as PFS or response rate. And also we have to take in mind that when dealing with a patient with hormone receptor positive, HER2 negative metastatic breast cancer, we have really an important heterogeneity in terms of biology of the disease as well as the clinical presentation. So we have patients with slowly progressive disease, bone-only disease, but we also can have patients with really aggressive disease spread to viscera. And I found very interesting this pooled analysis, which encompass both the Monarch 2 and Monarch 3 trials, aimed at evaluating among the variables potentially associated with the prognosis to identify those who are associated in multivariate fashion with the patient prognosis. And you can see that here ECOG PS performance status, tumor grade, progesterone status, liver mets, and bone-only mets were all the factors associated with patient prognosis. And these are analyses evaluating the efficacy of abemaciclib in combination with hormonal therapy in the two studies, Monarch 2 and Monarch 3. And you can see how this combination is effective in patients presenting with, for instance, with liver mets. And also we have data on evaluating the objective response rate. And you can see that the delta of the benefit is higher in patients with poor prognostic characteristics, such as PGR negative, such as presence of liver mets, or such as high grade. And here you can see that the combination results in up to 68% of objective response rate in patients presenting with poor prognostic characteristics. We already discussed about the relevance of quality of life in the context of adjuvant setting. Again, extremely important, as mentioned also in the metastatic setting, for the importance and the relevance in the also in contributing to the magnitude of clinical benefit score. And you can see when looking at all the symptoms, with the exception of diarrhea, and we already discussed about diarrhea, we see no substantial difference between the combination and the hormonal single agent. And as described for the adjuvant setting, and also Matt alluded to this in the first round of discussion, we have data in metastatic setting clearly showing that the reduction of the dose does not compromise treatment efficacy. So again, working on mitigation of side effects can be helpful to maintain patient quality of life, to avoid the onset of high-grade toxicity, and again, to make the optimal decision for our patients with metastatic disease. And this was my last slide, and I go back.
Great, thank you. Valentina, in terms of the first-line treatment, you've alluded to the pros and cons of the different treatments, the benefits from the trials of whether there's a survival benefit, the issue related to toxicities. What combination would you treat this patient with, the first-line patient who's relapsed 3 years after, who's got liver and bone?
I will offer a combination with the AIs, and I think she perfectly fit for the analysis of ABEMA poor risk group, because she has liver mets, progesterone negative disease. She has no issue related to the fact that diarrhea can be problematic in this patient, so I think is an option, but I think that also ribo can be an option for this patient.
So Matt, let's just put a little 10 years of age on the patient and up the level of comorbidities. Does that change your choice of CDK inhibitor?
I think it does, and we publish data as it relates to the issue of age, and as we get into patients that are in their 70s, mid 70s, we begin to worry a little bit more about diarrhea that can potentially lead to a little bit of dehydration, can lead to issues like falls, these sort of things. So I think in that situation, I'm more likely to use ribociclib in that situation.
Okay. And does palbociclib still have a role in these patients? Or do you think the data from the survival has tipped the balance because it's a very well-tolerated treatment combination? Many patients can be on the therapy for a long period of time. Do you think there's still a role?
I think my first-line therapy would be either ribo, especially in that older population, or as Valentina said, in ABEMA. I'm reserving palbociclib for those patients where there's a reason from terms of tolerability. I'm concerned that they may not tolerate ABEMA or ribo.
So this is our second-line patient. So remember, this patient only had 18 months of control with palbo and letrozole and has progressed. She has no evidence of any mutations, but she's progressed, I think, within the liver. So I hope you've all enjoyed the session. We promised to finish on time. There will be an evaluation to do. There'll be information to download or complete your post-evaluation service. Thank you very much to PeerView for putting this on. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and the European Board for Accreditation of Continuing Education for Health Professionals. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/SQE860.